This conference will now be recorded.
Well, good morning, everyone. This is Lindsay Sin, Deputy Secretary for Women Veterans for the California Department of Veterans Affairs, CalVet. Thank you so much for joining our September webinar. It is Wednesday morning, September 18th, 2019, and we are here today to talk a little bit more about women veterans health care, more specifically some reproductive and maternity care options. And we have two presenters from the U.S. Department of Veterans Affairs with us as well. Just a few housekeeping items that I'd like to go over before we get started. Please remember to mute your phones while we're on this call. We do record this call so that people who weren't able to join us can always go back and listen in and get the great information that's going to be shared. So please remember to do that. Hold your questions till the end as well. Typically, we'll have questions starting about 10:45, maybe 10:50, trying to give 10 to 15 minutes of discussion at the end of each call. And you can also ask questions through our chat window if you're joining us through the GoToMeeting software as well. To find our webinars, they're usually posted within a few days to a week after the recording. You can find those on our website, and you can find all of our past webinars on our website too. That's www.calvet.ca.gov/womenvets. Click on the monthly statewide webinars, and you should be able to view all of our past recordings. A couple of reminders: there will not be a webinar in October. We will not be doing a webinar next month. We'll pick up our webinar series again in November, and the topic and date will be announced sometime in the coming weeks. The reason we're not doing a webinar in October is because we'll be hosting our annual Women Veterans Reception on the evening of October 15th at 5:30 p.m. in Sacramento. This will be happening at the California State University Sacramento campus, and we invite anyone to join us for that evening event. We will be recognizing a few outstanding women veterans there as well. It's free to the public. We just ask that you register, and you can do all that through our website, or you can contact us via email, womenveterans@calvet.ca.gov. So moving to our webinar today, we are concluding the three-part series on women's health. Today we're going to discuss a little bit more in depth about some reproductive health care options at the VA, as well as some of the maternity care options and services that the VA offers. There's also additional information in this presentation about other health services that might be available to women veterans through VHA. This is an important topic because women veterans are more and more entering the military, of course, and then as they become veterans are still in reproductive age and are seeking the VHA services more often for their health care needs. And then women veterans, compared to their non-veteran women peers, are also more likely to be married and more likely to have children. And then, of course, we'd like to see continuous improvement in some of the services that are offered at the VA for women veterans in all aspects. And it helps to have these types of dialogues and discussions so that we know what's available and where we can continue to advocate for improvements. So with that, we're going to get started. I'm going to introduce our two speakers, and then I will hand it off to our first presenter today. Our two speakers are Carrie Kyrese. Carrie Kyrese is a board-certified family nurse practitioner with over 20 years' experience as a primary care provider. She holds a Doctor of Nursing from Johns Hopkins and a master's degree in nursing from Barry University. She's been with the VA for over 10 years and is currently serving as the Deputy Field Director for Area 2 and Women's Health Services VA Central Office. In addition to Carrie, we also have Heather Abel. Heather is the certified nurse and earned her Master of Science in Nursing degree from Benedictine University. She joined the VA in 2013 as the Maternity Care Coordinator for the Greater Sacramento region, and she also is often detailed to work under the leadership of the Reproductive Health Team for Women's Health Services VA Central Office. And in her current role, she also manages the VHA Office of Community Care on Clinical Integrations team as a Clinical Integration Process Management Nurse. We'll just forget that I said that. So both of these ladies are doing incredible work and are going to be able to give you great information about reproductive services and maternity care services with VA, and hopefully answer some of your questions that you may have at the end. So with that, I'm going to go ahead and hand this off to Carrie Kyrese, who will begin her presentation. Carrie, thank you so much for joining us.
Well, thanks for having me, and good morning. I just wanted to say how happy Heather and I are to be here and to share with you the work that we're doing. It's important to recognize, and I think you did a good job, Lindsay, highlighting that, you know, women are the fastest growing population at the VA. While there's still a strong number, or a lower number, we really are rapidly trying to improve the care that we provide for women and make sure that we're up to date with all of their needs. So I look forward to sharing this update with you all. So next slide, please.
Do you want this one, Carrie, Women, Veterans, History, and Demographics?
Yes, I don't see it on my screen though.
Oh, it looks like something is paused a bit. Hold on. Okay, there you go. It's up.
Still hasn't changed for me. I don't know if everyone else can see it.
Oh, I'm sorry about that.
Oh, there it is. Perfect. Okay. So thank you. So, you know, this is just a brief review of women, veteran history, and demographics. And this is kind of what's important to understand as we lead into the women that we're serving today at the VA. You know, as time has gone on, the amount of women in the military and their roles have changed over time. And so as of today, we're really looking at women being about 15% of the active duty force and 18% of the Guard and Reserves. Next slide, please. So growth in women veterans in the VA, as I talked about, has been pretty phenomenal. So women have accounted for over 30% of the increase in veterans that we've served between the years, fiscal years FY 14 and 18. That continues to be the growth trend. Women are now about 8 to 9% of VHA patient users. There is a difference. So VAs that are close to bases could have as many as 10 to 12% of their population. And then rural VAs that are far away from bases could have as low as 6 to 7%. So that's kind of why we get the average of around 8%. So while not all veterans come in for care every year, we have provided care to more than over 600,000 unique women veterans over the past 5 years from FY 14 to 18. Next slide, please. So this is just another example of showing you how we've grown over time. And this is pretty much could be fluctuating at different times, but you can see that the number of women of veterans in FY 18 was around 510,000, and that's up at least a good 10% from 2015. So we're having rapid growth of women who are seeking care in the VA. Next slide, please. So this is interesting to understand about the age distribution of women who are using VHA. When you look at the dotted line, this is in 2009. So we're talking about 10 years ago. So you could see that, you know, our average age then, you know, was around a peak at age 25, and then a peak at age, say, 45 to 55, and then a peak around age 85. So now about 10 years later, what we're looking at is still kind of that trend. So we've really modified and looked at what our current needs are going to be based on this. So as of last year, we're still around age 25, but you can see those 25-year-olds had stuck with us, and now we're in that 35 to 45-year range. And now we have our next peak at 55 to 65. And then finally, you can see our older population is actually leveling out a little. The other thing to note about this graph is the majority of our population is on the much younger side. So as we talk about some of the reproductive health needs and services that we've implemented, we talk about the reproductive life health of a woman. So that's their younger age, middle age, and older age. So next slide, please. So it's important to understand that the VA provides a full continuum of health care for women who are enrolled in VHA. So just briefly to review some of this, I think it's really important to understand the scope of the care that we're providing. So the first that's really important to understand is that we provide comprehensive primary care. So our goal for Care for Women's Health is that all of women's care is done by one provider in one setting. And that's a little different from if you think about sometimes in the community where you see your primary care provider for your routine care, but then you end up going to the gynecologist for your pap smear or breast exam. So what we've done is made sure that our providers are trained so that all the women can get their care from one provider in one visit. So that's new for a lot of people. And the reason we did that is we recognize that the quality of care is better when it's received by one provider, and it's equitable care because when a man goes to the VA, he can get all of his care in one visit, and so can a woman as well. So the next thing is routine gynecological care. So I talked about your annual, can you go back to slide, please? Thanks. So I talked about your annual pap smear, and that's really kind of routine care. We also have gynecological care at majority of our facilities, and that's specialized care. We have mental health programs that have specific programs that have been created to meet women's health needs. And this is important because mental illness in women is different than men, and the scope of illnesses as well as PTSD, MST, and other conditions that are uniquely known to our population many times represent themselves different in women. And so we need to be knowledgeable about how to assess that and also treat that. So disease management, prevention, and screening is your normal care of screening, which is your immunizations, your diabetes, your cholesterol. That's all done with your routine visits. We have emergency providers in all of our facilities who have been trained in emergent care conditions that are common among women. All of our emergency rooms have women's health champions there to help make sure that the staff is up to date and comfortable caring for women. Infertility care is had a lot of interest lately, and Heather's going to talk a little bit more about that. Maternity care as well as newborn care. So maternity care is primarily covered in the community, and the reason for that is we don't have the volume or proficiency within our facilities to provide that care. So what we do is allow women to seek a provider in the community and arrange a contract with that provider to not only provide their prenatal care, but also their labor and delivery care. Right now, VHA covers up to 7 days of newborn care, and that is based on congressional law. Specialty care, so we know that women have certain specialty care needs that are different from men. So we know that women in the VA routinely seek musculoskeletal care, mental health care, rheumatology. So certain specialty services women are receiving additional and different types of care, as well as all the other specialties that are available to all veterans. Hospice and palliative care and long-term care services and supports are the same as all. So everything that we have available for men is available for women. Next slide, please. So this is just a little bit about reproductive health of women veterans, and I'm going to just kind of get you prepared for Heather to talk a little bit about the services that we're providing. But if you remember the peaks that I talked to you about, so you know, those peaks really coincide with 3 major stages of life for women: our childbearing years, perimenopause, and menopause. And then when we look at our veterans, you know, our veterans could be coming to us at any time while they're in the military, in between deployment and combat, when they separate from the military, and then when they leave the military and they're in their veteran status. So reproductive health needs that are important in women less than 45 years are menstrual health and menstrual health disorders, contraceptive, pregnancy, and infertility, as well as we have routine screening that occurs throughout a period of women's life, which is cervical cancer, menopausal issues, as well as osteoporosis and breast cancer screening. And finally, conditions that we have recognized occur across the spectrum of women's health care is really sexual dysfunction, sexually transmitted infections, pelvic floor disorders, urinary conditions, including incontinence, and gynecology, basic and specialty care. So it's really important to understand that we have recognized that there are unique reproductive health needs. So a lot of our women who have been deployed have some unique areas of menstrual health problems, sexual dysfunction, urinary conditions, pelvic floor disorders. So we know that these are areas that we need to focus on with our population. Next slide, please. And I'm going to turn it over to Heather now. Thank you.
Hi, thank you, Carrie. Carrie highlighted all of the care that the VA provides. The care the VA provides has always historically been what's considered covered in the medical benefits package. And infertility evaluation and treatment, such as counseling, genetic counseling, diagnostic testing, ultrasounds, and even intrauterine insemination has always been covered in the medical benefits package. And every enrolled veteran is eligible for benefits included in the medical benefits package. However, what's recent and new as of the last couple years is in vitro fertilization for veterans. And this is new as a public law, started as a public law, whereby in vitro fertilization is now covered for veterans with a service-connected disability that results in the inability of the veteran to procreate without the use of fertility treatments. And even more so than that, as if that wasn't good enough, now we also, that same law provides for care for that spouse of the veteran. So the medical benefits package does not include care other than to the veteran, but this new law and regulation that was passed now covers not only the service-connected veteran, but also their spouse for in vitro fertilization and other infertility treatment. So we'll go a little bit further into that later on. Next slide, please. So this slide, it's really kind of busy, but I just wanted to highlight that there are two pathways for infertility care within the VA. And one, as I discussed, was the medical benefits package, and that care is under the policy or directive of 1332. So the title of the slide is VHA Directive 1332. And again, it's available to all enrolled veterans, meaning male and female veterans. So this slide really depicts what we have available in the current medical benefits package for the female veteran. And if you go down the list, it's pretty comprehensive, the infertility services available to them, as well as the infertility services available to the male veterans. I do want to highlight at the very bottom, it talks about intrauterine insemination, and that VA covers up to 6 cycles per pregnancy of intrauterine insemination, as well as cryopreservation for medically indicated conditions. So female veterans can get their eggs cryopreserved, and we cover storage for up to 5 years for that medically indicated condition. And as well for male veterans is also a cryopreservation benefit for sperm cryopreservation for medically indicated conditions. Did somebody want to say something?
No, sorry.
Oh, okay, sorry. So this list is just a comprehensive list of what's available in the medical benefits package available to all enrolled veterans. Next slide. However, with the introduction of in vitro fertilization eligibility benefit, the regulation is very specific with who qualifies for or who is eligible for infertility services, specifically ART IVF services. So we're not discriminating against people. It's just how the law or regulation was written. The act of Congress to get it changed. It was an act of Congress to initiate it. So we just have to really be good stewards as a VA of the eligibility criteria set forth in the law. So the law requires that the veteran be evaluated by a VA or a community provider and receive an infertility diagnosis. The veteran must have a veterans benefit an official VBA adjudicated service-connected condition that has caused their infertility or is related to the cause of their infertility. The veteran must be legally married to an opposite sex spouse. The male veteran must have testicular tissue from which sperm can be retrieved or have previously cryopreserved sperm. And the female veteran must have presence of an intact uterus and at least one functioning ovary.
I have a question.
Sure.
My wife is a veteran, and I'm a female. We're married. We're two females married, and we just finished going through IUI. Was that IUI supposed to be covered under the VA? Because we paid out of pocket.
IUI is a covered benefit for veterans. The donor sperm would not have been covered.
But the procedure of the IUI should have been?
Could have been, yes.
Okay. Thank you.
As included in the medical benefits package. Yeah.
Okay. And that's
And
1332.
Correct.
Okay.
That's the policy. Yep.
Thank you.
And I just want to highlight on this slide before we move on, the reason why we have that third bullet down, the veteran must be legally married to an opposite sex spouse. Our policy mirrors pretty closely the DoD policy, and the DoD policy has exclusions to it, whereby we have exclusions to ours now, where we exclude donor eggs, donor sperm, and embryos. We also exclude surrogacy. So I just wanted to be clear that that's where that stems from, and also to be clear that what the VA covers provides for biologic offspring of the veteran and their spouse. So that's why there's no donor egg, sperm, embryos, or surrogacy involved in this regulation. Next slide. So this is kind of the from start to finish how the public law came about. So we had the legislation, then it goes to the regulation, then we have the policy and procedure. We do have a policy or directive in the VHA that's not published yet, and it's VHA Directive 1334. However, we were able to start implementing this through our care in the community or community care program through the VA after January 2017, after the regulation was released. We are currently implementing it through the Office of Community Care to contracted community providers. However, the policy is not yet published. So it's currently available to eligible veteran couples at this time through the Office of Community Care. Next slide. So I mentioned one of the benefits in the medical benefits package is oocyte cryopreservation. That is covered for the female veteran in accordance with generally accepted standards of the medical practice. And that we cover for 5 years of storage for that. Then we also have to highlight that the VA is not in a contract with the veteran or the fertility center when it comes to the storage of those specimens. It's governed by the applicable state laws, and the contract or the agreement or legal form is between the veteran and the fertility center. The VA is not part of that contract, but we do cover oocyte cryopreservation for a medically indicated condition and the infertility pathway. And then in the IVF pathway, we cover oocyte preservation, sperm preservation, and also embryo cryopreservation for the lifetime of the veteran. Next slide, please. Now we'll go into the VA maternity care benefits. Maternity care benefits are also those benefits included under the medical benefits package for enrolled veterans. The VA does not cover the services in-house. We authorize the services through the Office of Community Care to a contracted community care provider. We have very limited resources within the VA to offer maternity services, so most often the pregnancy is confirmed within the VA and then it's outsourced to a community care provider. But the medical benefits package and the maternity care benefit includes prenatal care, labor and delivery, postpartum care, including lactation support for up to 8 weeks postpartum, and then the 7 days of the newborn care. But the majority of all of this care is done within the community in collaboration with our community partners. Next slide. So this slide represents, because the fact that the VA does not do maternity care per se in-house, it represents the need for the VA to employ care coordinators specifically for coordination of care for maternity services. So maternity services, as I said, are a benefit of eligible or enrolled veterans. So they're already in the VA system. So we're hoping that by being in the VA system, they're already receiving preconception care. Their providers are prescribing medications safe for their reproductive years, as well as once they do have a confirmed pregnancy, then that care is outsourced to the community. However, that does not stop the fact that the veteran still can come back and forth to the VA for certain services. She's not cut off from the VA while she's pregnant just because she's receiving community care for her maternity, outside of the VA. So we have that that liaison or that care navigator to help coordinate the needs of the veteran while she's getting care in the community, but she could also still be getting care within the VA. And that's really important too, because that veteran is expected to fill all their medications within the VA. And so sometimes, as you would recognize, there would be needs for the VA to know what's going on in the community. We are authorizing the care in the community, but that coordination and communication back and forth and that co-management, if you will, of services happening on the outside versus inside the VA. So there are maternity care coordinators established within the VA to help with this clinical navigation and care coordination during this almost 1 year period of time for veterans who are receiving care in the community. And the expectation is that that veteran would be fully reintegrated back into the VA within 12 weeks after delivering the baby, and then that those records would then also be transferred back to the VA so that VA providers would be privy to that information, and that would be uploaded into their medical record for future care. Next slide, please. This slide is really interesting, and it just really depicts the type of veterans that we're authorizing for maternity care in the community. And if you'll notice, the blue line is the percentage of veterans that have used VA benefits, prenatal benefits. So the dark blue bottom line is the veterans utilizing the maternity care benefit. And if you'll notice, more than 50% of them have current PTSD symptoms. About 45 of them have current depression symptoms. 10% have history of PTSD. More than 60% of them have a history of depression. And greater than 50% of them have a service-connected disability of greater than 50%. And I just wanted to highlight this because these are the, we know that a history of mental health disorder or history or current symptoms of mental health disorder is a risk factor for preterm delivery and just for prenatal complications in general, as well as postpartum complications. And so we really wanted to highlight the fact that a large percentage of our veterans do go into their pregnancies with a current mental health disorder or a history of one. And just to highlight that need, that they're at greater risk. And so it further necessitates the need for that close care coordination while they're getting their prenatal services on the outside, but still linked to the VA. Next slide, please. And I will turn the time back over to Carrie.
Thank you. So thank you, Heather. And so I think it's really important that we talk about what types of services we have available. So, these are ongoing from the moment we see a veteran at the VA for care. Is this evaluation of where they're at with their mental health? And really important because Heather highlighted the impact on reproductive health. But really, we want to address veterans' mental health issues and help her be as healthy as possible so that she has a positive maternal and fetal outcome with her pregnancy. So, a couple of these things we've already talked about: PTSD, depression, anxiety. But, some of the things that really impact reproductive health are on the bottom part of this slide. And, we're starting to learn more and more about our female veterans with eating disorders. And we know that their nutritional status directly impacts their pregnancy. So we have a lot of programs now. Each VISA now has an eating disorder specialty group. So they're really working on screening and groups and outcomes and ways to help identify eating disorders and also then provide the veteran with resources. We know that the opioid dependence is a problem throughout the country as it is, but because of many of the musculoskeletal injuries that our women encounter through serving in the military, and that's like a whole other lecture related to their the equipment they wear, all of the different things that they and the jobs that they have. So many of them have pain. And so, we kind of have to navigate that. How do we treat their pain and keep them functional so that they can be healthy and happy as well as during a pregnancy and postpartum? And then the bottom two, tobacco use and substance abuse, binge drinking. So, these are processes and substances that we screen for at every visit. Wanting to understand if there's any way that we can intervene and help. Both of these as well, tobacco use and substance abuse, have a direct impact on poor maternal and fetal outcomes. So just wanted to highlight that while we have the normal array of healthcare services, we do focus on women specifically because we know that they need to be as healthy as possible when they deliver. And I think the other thing that's not on this slide, but the VA has done a really good job at is, so most of these conditions require medications, and some of those medications may cause some impact the fetal anatomy. And so we've have some processes in place and alerts in our electronic health record that help providers counsel women and make sure that if someone's intending to get pregnant, that we've modified, adjusted, or changed their medications so that they can be as healthy as possible without having to abruptly stop them once they become pregnant. Next
I have
slide,
a question
please.
about that.
Sure.
Ma'am.
Yeah.
My wife, when we started on our journey for the IUI, my wife, she's the veteran. She asked her therapist and told him, she's on all these current medicines for her PTSDs and nightmare medications and everything. And they just straight up told her to stop them all, like just stop it. So she went off a little at a time, but now she's not taking anything, no medications at all. She's going through all these hormonal change. like just 2 weeks ago, I had to stop her from jumping out of the car because she felt like it was the end of the world. And I was just like, calm down. It's just probably your medication. You haven't taken it in a while. And so she's adamant about listening to her doctor and not taking any medication because she's supposed to try to get pregnant right now. So
Right,
am I
right.
to believe that they gave her the wrong information, that she was supposed to get a different kind of medication, or?
Well, I think each person is different, right? So each treatment team evaluates the impact of, how severe their situation is versus what medications they're on. So what I would say is I think it's critical to communicate with the team that she's having these issues. In my experience, it's been a balance, right? It's a balance between being, as healthy emotionally as you can be, yet still continuing to be, to get pregnant. And so we have many women who stay on medications while they're pregnant, that they're modified or there's a reduced dose, but that's because we know in the long run the benefit to them having the medication, and it's been their decision to stay on it. I think the other thing, it depends on what the medications are and what the side effects are. So there's a lot of medications that we use to treat depression, anxiety, that have like an impact on the infant, like a serotonin response, but it's not so much causes a type of abnormality in the development of the baby. So my point is, everyone's individual. And what I think, and I know either Heather or I would be able to, but you could email us and we could help you navigate where the facility where she's going to make sure that they've had, the conversation that they need to have. But we don't blankly do one or the other. It's a decision made by the treatment team and based on the individual veteran's history and so on.
Okay, thank you.
You're welcome. Next slide. So risk of suicide for women veterans. So it's actually 2 times higher among female veterans compared with the U.S. civilian adult women. So, we are sensitive to this and understand this. We've also found that rates of suicide is higher among women who have experienced military sexual trauma. And so I'm not sure how familiar you are with the definition, but military sexual trauma is a sexual assault or harassment that occurred during military service. So we find that we also have a higher rate in suicide of women who have experienced MST versus women who have not. Next slide. So risk of suicide, is something that we screen for all the time. Every visit we do depression screening, and if that's elevated, we know that women are more likely to die by use of firearms than non-veteran women, and that, of course, is probably due to their familiarity with that from their military experience. We must ask women and screen women if they have access to a firearm and work with them to increase the time and distance between an impulse and an act. So some of the things that we do within the VA is we provide free gun locks for all veterans. We encourage veterans to remove the ammunition and store it elsewhere. We also have requested many times that veterans give the gun to a friend. Next slide, please. So SAFE training is really one of the popular trainings that we do, and it's just so easy to incorporate the mnemonics here for everybody, not healthcare people, not VA people, but everybody. So we try to share this slide with everyone. So SAVE is the mnemonic for identifying the signs of suicide, ask questions, validate the veteran's experience, and then escort the veteran to care and expedite treatment. So, if you have someone that you're dealing with that you think is suicidal, make sure you ask them, are you suicidal? Are you thinking of hurting yourself? And then, let them know that you understand and that you want to get them some help. So many times people don't ask, but it's very important. So we like to share the idea of the SAVE training with everyone. Next slide, please. So if people aren't aware, suicide prevention services, we have suicide coordinators at each facility, but we work on peer support being available in women's clinics. We promote the 24-hour-a-day crisis hotline, and there's also a crisis online chat. So there's 24-hour resource for families, friends, veterans, anyone who needs help with dealing with suicide or suicidal thoughts or any family needs related to that. Next slide, please. So vet centers. Include individual and group counseling in areas such as PTSD, military sexual trauma, alcohol and drug assessment, and suicide prevention referrals. So all the services are free and strictly confidential. So it's interesting, the vet centers can see your VA record, but we cannot see theirs. So a lot of people have a comfort level with going to the vet centers. So you have to have been in combat in order to be eligible for care or have been diagnosed with MST. But these are excellent, and I know a lot of my female veterans go to the vet centers as well. They can also provide family counseling, which is great as well. Next slide. So we're moving forward with really advancing our care to include complementary and integrative health services, and we know through research, women, not just veteran women, but all women do well with complementary and integrative services. So these are mind-body techniques, meditation, mindfulness apps, yoga, tai chi, massage, art and music experiences. So all VAs are working on what we call whole health model, where we're trying to make sure that we work with the veteran to meet their needs and to make sure that we incorporate complementary and integrative health within their treatment plans. Next slide. So healthy aging, we've talked a lot about the women of reproductive age and what we do, but, the largest group of our women is 45 to 65. We recognize that as women get older, they can easily lose one activity of daily living. This has a lot to do with impacts independence, financial stability, and so on. So we know historically women outlive men. And this can result in a reduced income and housing issues. So our goal with healthy aging is to keep the veteran as healthy as possible, keep them in the home, and keep them functioning to their highest level. Next slide. So telehealth and connected health is also another great program for us. So first of all, on the left-hand side of the slide, just to highlight, so these are mobile apps that our office has created, and they're available to everybody. So you can go on your phone and search for them. And so really, you can see preconception care really talks about how to be healthy when planning a pregnancy. Caring for Women Veterans is an app that we created for outside providers who might be seeing women who don't come to the VA, so they can understand some of their unique needs and what they should be screening for. Maternity care coordination pretty much focuses on what Heather talked about. And the Safe Women RX, which is really good, is the other app that I talked about with regard to medications and seeing if those medications interact with pregnancy or lactation. So you can download these and take a look at them, but they're available to everybody. And then on the right-hand side is about our telehealth services. So VA is really doing a lot to work on telehealth care. So we provide telegynecology, telemental health, telewellness, and telepharmacy. So this is an example of, I email and I do these visits myself. I email the veteran a link. She clicks on the link. We both open our page, and we have a secure interaction, as well as can, do basic assessment go from there. So a lot of veterans are receiving a lot of care via telehealth. My Healthy Vet is our secure portal where you can email your provider, get refills, check your lab results, and then there's other apps that are great too, PTSD Coach, Move, weight loss apps, and so on. So just go to the VA App Store and you can download these. They're available to everyone. Next slide, please. And this is just an example of what it looks like when you meet with your provider. So you can see the provider is meeting the veteran in her home, and they are having a telehealth visit. Next slide. And the Women Veterans Call Center is really important for everyone to know about. This number that you see here, the 855 VA Women, is a program where you can call there and let them know of any concerns that you have. And what happens is if the person who's received the call can, help you at that time, they will. If not, they will route your call to the facility where you get your care or your closest facility in the Women Veteran Program Manager. So every VA has a Women Veteran Program Manager who's there to advocate for women veterans. So not only do they take your calls, but they do outreach as well. And so this is a very active part of our program to assist women. Next slide. So homeless services, so we know again that many of our veterans are at risk for becoming homeless. We do a lot as well with homeless veterans. We screen for them, and we actively are engaged with the homeless veteran program at each facility. Here are some resources as well to find out more about programs for all veterans who might need these services. Next slide. So prosthetic equipment. So not only do we have, what you would normally think of as prosthetics, and you see a female here with a prosthetic, with the prosthesis on her left leg, but we also provide breast pumps, nursing bras, wigs for hair loss, long-acting reversible contraception. This would be like the Mirena or an IUD. Maternity support belts, vaginal dilators, women's eyeglasses, shoes, etc. So everything that we have for prosthetics, we do have gender-specific supplies, and this is important for people to understand. Next slide, please. So we're working hard on culture change in the VA. We want women, when they come to the VA, to feel welcome and to feel like she's recognized for her service. And so these are some of the culture change posters that we've created that we distribute to facilities to help veterans be knowledgeable that, women have served too, and how to respect them and acknowledge them for their service. Next slide, please. So I don't know why.
There's a bit of a delay for some reason. I think it's the software.
Okay, that's fine. Anyway, just another example of our slide, which is on featuring the VA. Just another example. You can go to the next slide. So I think it's important to know that we've recognized there's been some research that showed that some women experience harassment when they come to the VA, women veterans and female staff. So we've done a lot with educating veterans as well as staff at facilities how to identify harassment and how to address it at the level where they receive it, where they view it. So this is just one of our posters that helps people understand, what is a compliment and what is harassment. Next slide, please. This is just another example of awareness and education that we use for imaging. Next slide. And I think another program that's really important to highlight is that we recognized that there was a disconnect between women leaving the military and coming to the VA, and getting them to understand the services that were available for them. And so we've received funding and approval for this TAP program that we've created. So it started with the Air Force, but what we've done is we have partnered with all of the services now, where we give them a presentation on healthcare at VA, and this is just for women in the military. And then we actually give them a tour of the facility, we register them for care, and we track them for 2 years post-service. So this started in about 8 sites last year, and it was actually adopted, and there's some congressional funding to move it forward. So you should be hearing more about this. So we are actively engaged working with them to make sure that women who transition from the military understand the scope of services that are available for them at the VA. And the next slide, I'm going to let Heather finish it off. Thank you.
Thanks. So Carrie highlighted all the different benefits and coverage and services the VA offers. One of the biggest buzzwords right now in the VA community is the Mission Act. So I just wanted to highlight what it is about the Mission Act that is beneficial for veterans. The Mission Act basically was enacted in June of 2019, and it replaces the Veterans Choice Program, which is another hot buzzword. The Veterans Choice Program is retired, and the Mission Act is taking over. And it basically is an act that improves veterans receiving care in the community. So it improves the veteran community care program, providing more choices and robust care for veterans using one consolidated program instead of multiple programs. At one particular time in my service within the VA, there were 8 different modalities for which a veteran could receive care in the community. So the Mission Act is really important for consolidating all of those different programs into one referral program so that it's easier and care is more streamlined, so that the veteran can receive the care that they need when and where they need it. And so I wanted to highlight this not because it really has anything to do with maternity or IVF, because those are specialty services that we don't cover within the VA. That's one of the 6 eligibility criteria for the Mission Act, is care or services not provided within the VA. So it doesn't really change the way that we provide maternity care or IVF services, but it is one of the 6 eligibility criteria for a veteran to receive care into the community. So I just wanted to highlight that the Mission Act really is for the veterans, and it really does help accelerate or improve access to the care that the veteran needs, whether or not we could do it within the VA or outside of the VA. The veterans deserve the care that they've earned, and so the Mission Act really is going a long way to help make sure that veterans get the care when and where they need. There are access standards that were improved so that we have drive time standards for primary care, mental health, and non-institutional extended care. Any care that is greater than 30 minutes from the veteran, they would qualify for receiving that care in the community. Specialty care, anything greater than 60 minutes, they would qualify for care in the community. And also wait time. If a veteran wants to receive a primary care or a mental health appointment within the VA, if they're expected to wait 20 days, if it will take greater than 20 days to get into that appointment, they automatically are eligible to receive that same care in the community. Specialty care is the same thing. If they have to wait greater than 28 days for that specialty care, they automatically qualify for care in the community. So this slide just highlights the different eligibility and access standards that have been relaxed as part of the Mission Act moving forward.
Okay, so thank you both, Carrie and Heather, so much for that great presentation. You guys have provided an incredible amount of information for everybody on the call, which will be recorded, and we will post this, and it will be available to people. If you want to request a copy of the PowerPoint slides, you can also email us, womenveterans@calvet.ca.gov. A couple other things, we'll open it up for questions if anyone has any additional questions to ask in about a minute. You are always welcome to contact our office at the California Department of Veterans Affairs if you have additional questions, and we can help you navigate or get you in contact with some of the folks at the VA for your healthcare needs. Then consider us a resource too in terms of knowing some of these programs or getting you in touch with the right people. So our dedicated women veterans staff are here to do that, as well as staff within the rest of the department that focus on veterans benefits. So please contact Calvet if you need us. A couple of things that you all mentioned, people may want to ask questions, whether it was about Mission Act eligibility program, consolidation for the other programs that included the Choice Act. People may want to ask about some of the additional services that VA provides. It looks like one question we just got from the chat window from Kate O'Hare Palmer. Have you seen an increase in problems filling, I assume that's full-time employees, FTEs at CBOCs after the Mission Act program started? So is the Mission Act impacting hiring at the VA CBOC?
Well, this is Carrie, and what I'll say is I'm not really sure because Mission Act just started. So I don't know if we can really attribute anything to that. I think overall we know that CBOCs in rural areas sometimes have some challenges with hiring providers, but I can't speak to the Mission Act impacting that at this point.
This is Heather.
Oh, go ahead, Heather.
And I can tell you that we have received, not specifically with hiring at the CBOCs, but we have received in some instances at some specific stations greater than 40% increase in community care referrals. So the access is opening up care to the community more so. So I can't speak to the internal hiring at the VA. I can speak to the care that we're referring to the community as in some instances been greater than 40% increase since the Mission Act referrals to the community.
So, yeah, maybe there's not a cause and effect there to answer Kate's question, but clearly the impact of the Mission Act is already is well demonstrated. I think the biggest concern that many of us have is that there's a balance there, that people are able to access through the Mission Act and some of the improvements that were made community care where they need it, but it doesn't impact the care that a veteran receives at a VHA facility, whether it's a CBOC or the actual health facility. You know, we want to see the continual backfill of empty positions so that we know we have enough doctors, we have enough practitioners, we have enough social workers. All of those jobs are still needing to be filled with the VA and directly impact the care that the veteran receives. So hopefully people continue to walk that fine line and notice those differences and can advocate for the improvements of hiring if needed.
There are other.
I was just going to say that we used to monitor access at 30 days, and we've switched it already to all the mission measures, so 20 and 28 days. So everyone actively is looking at our access, and so making some projections related to FTEs with that as well. So, we are looking at the impact of it within the organization as well, and how are we going to continue to meet the needs. So I think that's a great point. I appreciate that.
Okay. Well, that's good to know. It's good to hear that it's a key area of focus. Great. Any other questions from our callers, listeners, participants?
This is Heather, and I just wanted to put in one last plug for the VA, because I know it's been a real bad sore and something that we've had to really deal with reputation-wise is timely payment of electronic claims. Coming from maternity care world, I know that veterans really stress out and suffer from lack of payment or collections or, all kinds of financial concerns when it comes to receiving care and then being billed for it later. So I did want to highlight that one aspect of the Mission Act is to also improve timely payment, and the VA has been charged with having a new electronic claims adjudication management system to reduce all of these claims and reimbursement processes that have plagued the VA and essentially the veterans for all these years within the VA, and it is something that we're actively working on, and it will get better.
Well, I appreciate hearing that too, Heather, because we know that with women that you see, women who are essentially on a timeline to grow and deliver a baby, any placement they get into that third-party care is key. And unfortunately, as you'd alluded to earlier, the reports showing some of the more negative outcomes or adverse birth outcomes for mother and child that can happen when a woman veteran has suffered military sexual trauma or has a history of depression or PTSD. It's really imperative that she get care early and often, and that she's well connected with those resources. So, to veterans, I would say, make sure you're getting into your VA facility if you're planning to get care. Don't wait. If you're pregnant, or if you have a need for mental health treatment, and you're planning to have a family, get into care as soon as possible. And then, hopefully the VA will continue to improve its payment processes and it's not impacting your patients too much, Heather, because that's really key. So do we have any additional questions from our audience, or anything, any last comments from either Carrie or Heather as our presenters?
I have a question.
Absolutely.
Okay, so my wife and I, she's supposed to take the pregnancy test on Friday to see if she is pregnant or not. Do we wait till it's confirmed that she's pregnant to go to the women's healthcare area, or should she start the process and try to find care?
So is she's seeking care at the VA?
Yeah, like we went to an IUI and she already got inseminated with the sperm inside of her 2 weeks ago.
Yeah. Well,
so I was wondering.
Yeah, my suggestion is to start the enrollment process at VA as early as possible if she hasn't done so already. But Heather would be the expert on when the actual coordination for maternity care, should she be pregnant, when that would happen. Any thoughts, Heather?
Yeah, so typically veterans come to us after they've had a positive pregnancy test, either at their community provider or at home. Then she would initiate the phone call to her local VA women's health or gynecology department, and then they would start the process for her, bring her into the VA to be seen, and then start the referral process for maternity care.
Okay, so definitely wait till she gets the confirmation that she's pregnant.
Correct.
But okay, thank you.
But if she's not enrolled, she needs to enroll, because she needs to enroll, get assigned to a primary care provider, and that might take a couple days. So if you at least do that, once you have the diagnosis, then you can kind of see your PCP and get everything going in one visit.
Yeah.
Oh, so it's not a delayed response. Okay, so she should start the enrollment and then
sooner the
call
better
with the confirmation.
Yeah. Where are you located? What part of California are you in?
We live in Lancaster, but we drive all the way to the West LA VA. Like, we're at the West LA VA today.
Okay. Did she go into the women's clinic at West LA VA?
No, she's been telling me, she told me to call you guys today to listen into this, to find out information, what she should do next.
Okay.
And this is why I'm asking.
Wonderful. Okay. So why don't you want to send me an email, and then I can and then we can connect you with the Women Veterans Program Manager there and the Women's Healthcare Manager as well.
Yes.
Okay.
Can I have your email address, please?
Sure. Lindsay, Lindsey.
Okay.
Sin, that's SIN.
SIM
at calvet, CALVET
at calvet.ca.gov. Okay.
And then you can also email our Women Veterans email, womenveterans at calvet.ca.gov.
At calvet.gov. At
ca.gov. Yep. There you go.
Okay, cool. All right, and then I just give you the information of my wife and
Just say you're trying to connect. We talked on the webinar, you're trying to connect with the West LA VA, so the Greater Los Angeles Healthcare, and then we can connect you. I'll remember you.
Okay, sounds great. Thank you so much.
What's your first name?
My first name is Laura, Laura.
Okay.
And my wife is Leanne, Leann.
Okay. All right. Well, if I don't talk to you again, except via email, best of luck to you guys. That you get the outcome you want.
Yes, ma'am. I appreciate you ladies so much.
Absolutely. Okay, we should wrap up the call. I know we had one additional question, but I want to be respectful of everybody's time as well.
Okay, well, it's Carrie. Heather had to leave, actually. She had another call, but I can quickly answer this question. And then, Eric, if you have other questions, you can reach out. So Environment of Care is streamlined. We have a survey tool. Women veteran program managers at each facility participate in rounds. At the network level, we monitor progress of corrections. So that is a clear process in place. Outreach is not the same for each facility. We all do outreach, but it may depend on the resources at the local site and the programs that people have there. And then with regard to CBOCs, all CBOCs are required to have 2 women's health providers at each site in order to provide comprehensive care. So the policy is there. Sometimes with turnover and other things, there may be a gap, but overall, we do have policy that supports that.
Great. Thank you, Carrie. Hopefully that answered your questions. Eric, that was good information. Okay, so it is almost 10 after 11, so we went over a little bit because we had so much information and a lot of good questions. So thank you again, both to Carrie and Heather, and thank you for everyone that joined us. Look on our Facebook page and our email listserv for the announcement for the November webinar. We'll give you the topic and date and time shortly in the future. And then look for this information to be posted within the next several days so that if you want to go back and see the webinar, you can. Appreciate everybody here for joining and participating. And contact us anytime if you need anything at calvet.ca.gov/womenvets. Take care, everybody. Have a good day.
Thank you.